We're moving on to the next session, which is the Experts Forum, and we have 4 specialist talks. The title is The Strategy for Managing Reflux Post-Bariatric Surgery, which is very relevant. And if I could ask the speakers to stick to 9 minutes for each speaker, and there'll be 9 minutes of discussion at the end, so the speakers will follow each other and we'll do discussion at the end. So for the first speaker, I'd like to introduce my good friend and colleague, Dr. Sandeep Aggarwal. He's the chairman of the Minimal Access Bariatric Unit at the Manipal Hospitals in New Delhi, India, and he's going to talk about particularly relevant to sleeve gastrectomy.
Thank you, Vinod, for the introduction, and a very good morning to everyone. And at this outset, I'd like to thank Sanjay and Chetan for this kind invitation, and I'm glad to be at Homerton this time again. So I'll be talking about reflux management after sleeve gastrectomy, and I'm not going to go into why this happens and the pathophysiology of reflux, but just suffice to say that about 1/3 of the patients may develop some reflux symptoms after sleeve gastrectomy, whose severity may vary from very mild to severe reflux interrupting sleep and the lifestyle of the patient. It's important to remember that most of these patients do not require operative therapy or a very active intervention. And this has been borne out by 2 large-scale RCTs with a 5-year follow-up, which have compared, sleeve and bypass. And they, in these trials, it was clear that only 6 to 8% of patients with sleeve required conversion to RYGB for severe GERD. The problem requires a very stepwise diagnostic approach, and the therapeutic options are limited in the form of lifestyle interventions, medication, endoscopy intervention, and conversion to RYGB. Of course, in most of the patients, we start with lifestyle modification. We don't jump onto investigations and interventions. And the management includes, very importantly, dietary education to educate the patient to change their eating behavior modification. They have to eat small sizes. They have to avoid overfilling the stomach, because most of these times, it's not the reflux, it's not the heartburn, or that's actually the reflux of the food because of faster eating and eating more. And initiating PPIs in the therapeutic dose. And most of these patients have significant improvement of symptoms following these initial management. However, sometimes PPIs may not work, and and there may be a high rate of esophagitis in patients of sleeve gastrectomy despite PPI use. And that can be due to a multitude of factors, including presence of any morphological abnormality in form of hiatus hernia or a sleeve stricture, or due to changes in the esophageal motility, which can happen due to high pressure due to sleeve. So when you have a situation of a refractory GERD and sometimes also a food intolerance, you may need to investigate these patients further. And of course, the first investigation we do is an upper GI endoscopy and a barium esophagogram, which is important to look at the morphology of the patient. And depending on that, we go on to the further management. So these are some of the pictures from the patients referred to us, and sometimes our own patients, where we've shown the patient, some of these patients with severe reflux have anatomical abnormalities in the form of narrowing of the sleeve or angulation of the sleeve at the incisura, and sometimes you find a slight hiatus hernia on a CT scan, and sometimes a twisting of the sleeve. And interestingly, this patient may have a totally normal endoscopy, because endoscopy is able to maneuver all these abnormalities very clearly. So it's important to be physically present at the time of endoscopy, or do your own endoscopies when you're dealing with a patient with reflux. And this entity, which has been recently recognized, is the intrathoracic migration of the sleeve, which can be sometimes misinterpreted as Barrett's esophagus, and is a fairly common thing to happen because of the increased intrathoracic. This is one of our own patients with a intrathoracic migration sleeve, which is significant. So, which patients need conversion? As I said, only 6 to 8 patient would require a conversion to a bypass procedure. And these are the patients with severe symptoms, either subjectively, and severe symptoms mean they have a nocturnal reflux, they get up at night, they have a heartburn requiring daily PPIs, they have extra esophageal symptoms in the form of asthma or a chronic sinusitis, or they have a volume reflux, as you can see on a barium. And if you do an endoscopy, if they have an erosive esophagitis or a Barrett's, and these patients can be further, evaluated by a pH manometry and pH studies and a manometry to look at exactly what's happening at the, at the physiological level. So, this was the first international consensus conference on GERD and sleep, which was published in Obesity Surgery. And according to this consensus conference or meeting, patients with uncontrolled GERD and insufficient weight loss, 84% of the participants agreed that RYG should be recommended. Even patient with sufficient weight loss and GERD, RYGB is a procedure of choice. In patients with Barrett's esophagus, 78% of the participants said that RYGB is a procedure of choice. However, there was no consensus in a patient who had Barrett's and sufficient weight loss. So, so it's important to understand. Can I click this video? Can somebody click this video, please? It's important to understand that the conversion should go according to a very stepwise approach. We need a careful adhesive lysis. Of course, define the indication very clearly, counsel the patient, that goes without saying. How do I click this video? Press next. Okay. So as I said, this is a very old video which we converted early in our program. A patient who had lost good amount of weight with severe reflux. So you have to do a careful adhesive lysis. Sometimes the fundus is, the sleeve is adherent to the liver. Mobilize all the crura, define the anatomy completely, mobilize the esophagus into adequate length into the mediastinum. Do a create a short pouch, and then do a proper bypass, which will depend on the amount of BMI, the BMI the patient has. If the patient has a normal BMI or has lost a good amount of weight, then a short bypass is good enough. So it's just not conversion to bypass, but also looking carefully at the hiatus as well as repairing the hiatus properly, and also having an adequate length of esophagus into the thing. So this was one of the initial papers on the initial results by Chetan, who's sitting here, in which they compared conversion of sleeve to RYGB for reflux and weight loss, and they said it's a good procedure for reflux, and 9 out of the 10 patients with reflux had remission of symptoms, but however it's not a good procedure for weight loss. And however, most of the papers on reporting on conversion do not mention about hiatus, although Chetan did mention that chloroplasty was done in 4 patients. This is a recent study, the largest study, which is a multi-center study from Michigan collaborative database, which looked at more than 2,000 patients who got operated between 2014 to 22, where sleeve was converted to bypass for various indications. And the primary outcomes were GERD-related health, related quality of life measures, the use of anti-reflux medications, and weight at 1 year. The data was available for these primary outcomes in roughly 279 patients, although more than 1,000 patients underwent surgery for GERD. And if you look at the results, the GERD HRQL scores decreased significantly from 24.6 to 6.6, and of the 207 patients requiring anti-reflux medication at baseline, only 76 required it at 1 year. But still 76 did require medication. They were all not off medication completely. They were in a reduced dosage. But the most interesting part of the study was there was a worsening of reflux in 23 of the patient, which has not been reported by any other study or any other systematic review. And there was no change in 10.1% of the patients. And the possible reasons could be that one could be the technique. Like I've seen in a couple of workshops, people just divide the sleeve below the, and create a pouch without bothering about the hiatus. This could be one of the reasons for failure of conversion to, take care of the reflux. What about Barrett's? This again, patient dealing with 10 patients who were converted to RYGB for Barrett's, and they had an 80% remission of Barrett's after RYGB. This again showing that conversion to bypass remains the procedure of choice for Barrett's following sleeve gastrectomy. What are the new things? We all are aware of the magnetic sphincter augmentation for GERD for non-bariatric population, and there are more than 1,400 papers on LIBSS procedure alone. So its use in post-sleeve reflux has been, recently been tried in a few studies. For those who are not know, LIBSS device consists of a series of titanium beads with a magnetic core, which are connected with independent titanium wires to form an annular shape when implanted. And when the patient swallows, these sort of beads move away to allow for that space for distension. And these are placed laparoscopically following the similar principles as I showed in the conversion. We have to preserve the vagus nerve, and the device is placed through the window inside a posterior vagal nerve and outside anterior one. This is a very good paper recently published in obesity surgery by Dr. Ketan, and which showed on 30 patients with refractory GERD post-sleeve gastrectomy a significant reduction in the GERD scores and the PPIUs, which were very statistically significant. And there was a normalization of total acid exposure time in 44% patient. And more importantly, no serious adverse events at 1 year. This is again a systematic review of about 114 patients. And the most important takeaway is not only is it effective, there was only one case of LIBSS explantation in this review, showing, testifying to the safety of the procedure. So the take-home message is, reflux after sleeve is a significant problem, but most patients would respond to conservative management. We have to be patient, spend time, have a multidisciplinary approach, including a dietitian and a psychologist maybe. Those patients who do not respond need an evaluation with an esophagogram, an endoscopy, a pH manometry, and a 24-hour pH study. And after that, you make a plan. And intervention is definitely required if you detect a morphological abnormality, as I showed. The RYGB remains the gold standard and the most effective treatment for post-sleeve